Damage control surgery, what was a term coined earlier, and now it has turned to damage control resuscitation. The concept basically has grown over a period of time in the last 2 decades. However, it has been long back since this concept came into. So I'm going to talk about a brief history, how this concept came. What is the definition of this damage control resuscitation? When would you like to do that? Means what are the indications? There are phases of damage control resuscitation, stepwise, phase-wise, which I'll be discussing, along with briefly about the operative techniques, because this is not the talk about operative session, but it is just to give you the brief principles of damage control surgery. What are the modifications which have been adapted over a period of time? And then we summarize. So damage control surgery, basically the damage control terminology came in the First World War when the US Navy ships got hit by torpedoes. And the basic purpose was to keep the ship afloat, even by limiting flooding, stabilize the vessel, isolate fires, explosion, and avoid their spreading. So something similar we started, known as damage control resuscitation or damage control surgery. And what we try to do is to correct the physiology in these patients. Because as our understanding progressed, we came to know that there is in trauma, there's a triad of death, which is basically comprising of hypothermia, metabolic acidosis, and coagulopathy. However, in 2022, it was known as diamond of death by the addition of the fourth factor, and that is calcium. This may be because these patients were given a lot of blood transfusions, or maybe the calcium precipitant was there. Now, what was the aim when we tried this damage control resuscitation? Or what was the basic? Like in the ship, we had that we have to limit the fire, limit the flooding. So here, we have to limit the blood loss to prevent coagulopathy by combining hypotensive resuscitation, early airway control, damage control surgery, early and balanced use of blood products and other hemostatic agents. Damage control resuscitation was a term which was coined in 2007 by Holcomb. Now, it comprises a group of strategies to keep the patient alive. And that is what I'm going to talk about today. So if you go to the history, it was in 1983 that Stone and colleagues gave a word which is known as abbreviated or truncated laparotomy. What they meant was that if a trauma victim comes to them, basically this was by the war victims, if they have an abdominal injury, whether it is by a blunt or a piercing injury or a penetrating injury, these patients are already in a state of shock. So do the least to prevent blood loss, to prevent contamination of the fecal contents of the intestine spilling into the peritoneum, and don't do a definitive surgery and shift him to ICU. Rotondo and colleagues, however, the first time coined the term damage control surgery in 1993, when they emphasized on that besides laparotomy and ICU care, you have to divide it into 3 phases, where the third phase is the definitive care. And time is critical over here because the definitive surgery has to come into play within 48 to 72 hours. As our pre-hospital trauma teams started developing more in the West, in India, we are still in infancy, but we are developing. Johnson and Schwab in the West said that there is a 4-phase technique, and I'm going to talk about before we take the patient into the theater. So the concept was to keep the patient alive at all costs, treat what is killing him. That means the triad or what we call the diamond of death, and correct the physiology. So once you have corrected the physiology, the patient can undergo a definitive surgical management. So damage control surgery or abbreviated laparotomy is designed to prioritize basically physiological recovery or maintaining the hemostasis which has been disturbed by trauma, so that patient can be later on taken up for a definitive management. When damage control surgery was combined with all 4 phases, it came out to be known as damage control resuscitation, which involves a multidisciplinary approach, right from the pre-hospital trauma care, which is taking care, including the operating surgeons when the patient is undergoing the first surgery or damage control surgery, followed by the care by the intensivist in the ICU to correct the physiological disturbances which have arisen because of the trauma and surgery, so that this patient can be taken out for definitive surgery after 48 to 72 hours. The basic purpose is to minimize blood loss, maximize tissue oxygenation, and optimize outcome. Three phases which were initially described was phase one, when the patient was immediately taken up in OR. So whatsoever was bleeding was taken care by directly ligating it, irrespective of the nature of the vessel. Contamination, that means if the bowel is perforated, don't try to suture it. Just take small, if there is small perforation, you can suture. However, just tie it. You can take a simple roller gauze and tie it, so that that part is not getting contaminated. You can tie on both the ends so that from the perforation, there is no leakage. That is, the contamination is controlled. And when you try to do the abdominal wall closure, I will show you the pictures. Don't do a definitive closure. Just put a Bogota bag or just approximate the skin, because this patient will be shifted to ICU, followed by another surgery within 48 to 72 hours. Phase two is very important, and here your intensive critical care medicine physicians will be very helpful, because they know what is going on wrong, and they will help in resuscitation and stabilizing these patients by correcting the acidosis, hypothermia, coagulopathy, so that in 48 to 72 hours, you can re-explore them. As we go further, what happened is that we divided it into 4 to 5 phases, and these 4-5 phases have been developed as we started developing a good pre-hospital care system. So we said that we have to have a resuscitation, not only in the trauma center, but also in the pre-hospital care. So that followed by damage control surgery. This is followed by ICU resuscitation, definitive care. And what you see, the green, which is tertiary care or reconstructive procedures, which was known as the phase 5 nowadays. So this is what I was talking about. So phase 0, pre-hospital or emergency department with damage control resuscitation, followed by a bridge surgery, which should be over in 30 to 45 minutes. You are not going to do any definitive surgery. Just limit the blood loss, control hemorrhage, and limit contamination, followed by ICU resuscitation, definitive second phase surgery. And the fifth phase, which came as DC4, was reconstructive procedures, which were going on. So when are you going to the decision regarding taking up a patient for damage control resuscitation? If the patient has presently quite late after trauma, these are the patients who had a lot of blood loss. So what will happen is they will be in hemodynamic instability. They may be in hypothermia. In India, we have the concept that people, because outside is 39 to 40 degrees, there won't be hypothermia. You are mistaken that as the trauma, the blood loss, the hemostasis mechanism of the body goes down. And that is the reason that when you try to give them IV fluids, which are even at room temperature, they are much lesser. There may be 24 or 25 degree. And when you want a 37 degree and infusing with 24-degree fluids, this will further result in hypothermia. When hypothermia is there, majority of the coagulation proteins are not working, and that's why coagulopathy comes into the play. By the time the patient comes to you, because of blood loss, there is hypovolemia, there is hypotension, there is decreased tissue perfusion. So the oxygenation of the tissues is already compromised by the time he comes to you, and thereby resulting in metabolic acidosis. So in those patients who are coming to you late with features of hypothermia, or patients who are coming to with penetrating injuries, or patients, suppose they have come to you and this patient has been already given blood transfusion in the private setup or in a other hospital setup or on way and requiring more than 10 units of packed RBCs. These are the patients here. You don't try to do a definitive surgery at the beginning. Just stabilize the patient. To keep the patient living is our basic purpose. When we talk about anatomic, physiological, and lab parameters, anatomic features is the injury severity score of more than 36, penetrating abdominal injuries, whenever they are penetrating chest injuries, open pelvic fractures, long bone fractures, amputation with a massive hemorrhage. Now remember this thing, it started with laparotomy, but now it has been extrapolated to thoracic injuries as well as limb injuries. Similarly, the physiological parameters, when the temperature is less than 35 degrees, the systolic blood pressure is less than 100, there is tachycardia. When you talk about PaO to FiO2 ratio, which is normally more than 400, when it is less than 250, that is the time when you will be thinking Obviously, urine output is the parameter which tells you what about the perfusion. Now, regarding urine output, just one thing, if it is less than 0.5 ml per kg body weight in adults and 1 to 2 ml per kg body weight in children, you will be thinking that there is derangement. By the time the patient comes to you, and if you can send the parameters, you can work him up for coagulopathy at that time, the lactate levels from the arterial blood gases. Obviously, you do a hemoglobin to know hemoglobin and pH less than 7.2. Now, in ABG, 2, 3 things to be looked for is besides pH is base deficit and lactate levels that will decide that these patients are potential candidates for damage control resuscitation. So if you see the algorithm, if you have a trauma patient, you are looking at a stable patient, there the DCR has no role because you can do a fast positive or a fast negative with focus assessed sonography in trauma of the abdomen and thorax. If the patient is showing something, then you can treat it accordingly. If that is not, then you can do a CT scan in a stable patient. Remember, this thing patient should be stable before you send him for CT scan. And then you can manage him accordingly. If there's solid organ injury, you can take the help of your intervention radiologist to give angioembolization and then shift him to water. If there's no bleed, obviously you can observe. But it is this group, the unstable group, where if fast is positive, now this is unstable, fast positive, don't ever shift these patients to CT scan. Remember this thing, CT scan is only for stable patients. So these are the patients where you may require a immediate laparotomy and think about damage control resuscitation. So that's why it has a limited role, but yes, it has a role. The next thing is that you should know that when you talk about ground zero or phase one, which is basically the pre-hospital care, it is built on the principles of advanced trauma life support guidelines, where we talk about airway, breathing, circulation, disability assessment, and environment control. Now, this is basically a good course, and I recommend that all the students who have passed their MBBS or surgical residence should be doing this course because they come to know a lot of basic methods of evacuation of patients, what is to be done during transportation of these patients, and regarding basic life-saving procedures like an ICD insertion or taking an IV line, endotracheal intubation. Now, damage control resuscitation is basically to keep the patient having a systolic BP of 80 to 90 degree, 90 millimeters of mercury. This phase should take only 20 to 30 minutes because you have to take the patient immediately in the OR. Now, there is a good system abroad, which I think in India also we should be implementing, is that once such a patient is coming to the hospital authorities are already informed. So the surgeon who is on call knows that such a patient is coming who is bleeding. So immediately he informs the blood bank, he informs the OT, he stops air conditioning because you may have to start warmers, sterile towels. You will have to tell the OT to keep all the equipment for laparotomy, thoracotomy, vascular set, and that is very important. One thing, because a lot of students and postgraduates will be attending, remember there is something which is known as massive transfusion. What do you call it, massive transfusion? When it is more than 10 units of PRBC is required in 24 hours. Now, 25% of patients who are severely injured will be coagulopathic. When you have a patient of coagulopathy, the best investigation is a rotational thromboelastometry because it tells you, it guides you which product he will require, whether it is a platelet deficiency, whether it is a plasma deficiency, or whether it is a factor 7 or 9. So that is very good in knowing how to correct the coagulopathy. However, having said that, it is important that the institution where you are working, you have some protocol between the surgeon, the blood bank, the ICU, the nurses, and the ancillary staff, so that you have a good outcome of these patients. Now, a word about permissive hypotension. When we talk about permissive hypotension, here the basic concept came that if you give a lot of blood or resuscitate the patient with a lot of crystalloids, what is going to happen is the blood pressure shoots up. And if there's a clot which is blocking a bleeding vessel, it will just give way. So that the basic purpose is permissive hypotension means that you keep the blood pressure somewhere between 80 to 90 millimeters of mercury systolic. so that the perfusion of the vital organs is also maintained. At the same time, if there is a bleeding vessel, there should not be more bleeding from that. However, a word of caution over here to be told that in cases of patients who have brain injury or who have cranial injuries, where you're suspecting that there is a element of brain injury, here, because of whether it's a subdural hematoma or extradural hematoma or just a blunt trauma resulting in edema of the brain, there'll be increased intracranial pressure. So there has to be hypertension. That means the blood pressure shoots up, what we normally call as the Cushing's response, so that the perfusion to the brain is maintained. So here permissive hypotension will not have a role. So before you decide on this, please rule out that this patient's GCS is 15/15 or there is no element of head injury. At the same time, there is something which is known as hemostatic resuscitation. There were 3 trials conducted in Europe as well as in America, where they found out that what should be the ratio of packed RBCs, FFP, and platelets in patients who will require massive transfusions or those patients who are in coagulopathy and you want to correct it. What they found out was that the ratio should be 1:1:1 in patients who have lost blood or the patients who have come to you in coagulopathy, especially in trauma. And this is known as homeostatic resuscitation. The second stage comes is phase 2, where the patients you have resuscitated in your trauma bay, and now you have shifted this patient to the OR. Initially, what started as only damage control laparotomy, now it has been extrapolated to damage control thoracotomy, damage control vascular surgery, and damage control orthopedic surgery. So the spectrum is becoming wide and wide as our knowledge of damage control procedure or damage control resuscitation increases. Now, when the patient is taken in OR, the surgeon knows very clearly that he's not going to do a definitive repair. He's not going to do resection of the intestines, or he's not going to do an emergency RA. What he is going to plan is that he has to just control the hemorrhage. So whatsoever the vessel is bleeding, he will take a tie or he will take a ligature, figure of 8. If the bowel is perforated at many points, just take that loop of bowel, block it from both the ends and give a good lavage and put a big drain and come out. Don't try to suture it. The basic purpose is that this phase should not be more than 1.5 hours. In other words, 90 minutes, because you have to finish it, close the abdomen and shift this patient to the ICU. Now, as I told you that a person who is well versed with damage control surgery should know that he will require a good IV line, blood products, vascular instruments, effective suction, so that the trauma team and the sisters are very well trained. There's something which is known as auto transfusion. Now, remember this thing that auto transfusion can be only done if there is a thoracic trauma, there is no contamination of intestinal contents, isolated thoracic trauma where there's a blood which can be auto transfused after filtering. There are auto transfusion sets available. However, this is not available everywhere. So please remember, this is only exclusively for thoracic injury with no communication with any intestine or bowel contents. So it is not advisable in laparotomies where there is perforation of intestines. At the same time, a word about tranexamic acid, which has been shown by crash 2 trial that it is beneficial if it is given 1 gram within the first 2 hours of trauma and the second dose within 8 hours. So that has shown that it definitely helps in better prognosis. And in patients, you will be giving him antibiotics and analgesia. So normally there's no contraindication for this type of surgery because it's a life-saving surgery. So even if the patient is full stomach, we do something known as crash intubation where cricoid pressure is given to prevent aspiration and the patient is taken under general anesthesia. The patient is taken in midline position. It is right 3 passes from skin subcutaneous tissue. The first pass going from xiphisternum down to the pubic bone. Second layer is the linea alba, and lastly, the peritoneum. As soon as you enter the peritoneum, what you have to do is you pack the 4 cavities, 4 quadrants. You take towels, don't use mops. Here we use small towels to pack. each quadrant and gradually remove after we have we have sucked out all the blood, because there is so much blood in these cases that you will not be able to visualize. So what you can do is immediately put 4 towels which will absorb. At the same time, they will have some tamponade effect. And then in the meantime, you can do suction all around and then you can go ahead. Now what you do is remove packs one by one and then you can. Now, if it's a liver injury, the best thing is that do a perihepatic packing, that means around the liver. So there's a tamponade effect on that. The people have also described Pringle's maneuver, where you take through the gastro, to the lesser omentum, the window, Winslow window. You take it and completely pinch it or apply a vascular clamp till you can shift him to angiography unit if required, or you can just do a temporary measure, but you cannot keep it controlled for a long time. So if you do like this and do a perihepatic packing, that will be much better. When you talk about splenic injury, splenectomy can be done provided you are trained in that. Otherwise, just catch the main vessels and ligate it. Take a figure of 8, that is much. Minor injuries of the pancreas, you just require a drainage, nothing else. However, even if it's a massive injury where the pancreaduodenal complex is there, and if you don't have the expertise, remember, this is damage control. Just control the bleeding, ligate the vessel, what is bleeding, take a figure of 8 to control the bleeding, and put big drains. No need of reconstruction at this phase because this is damage control surgery, what you are going to do. In literature, they have told that even major vessels like carotid, subclavian, internal iliac, ICA, SMA can be ligated, including all the veins. Even IVC have been described because it's a life-saving procedure. However, when we talk about such procedures, we should be knowing that we have to explain the prognosis to the patient and the relatives. This patient may not be in this state, that we are doing everything to save the patient initially, and then we take a call. It is better to have a living patient rather than a dead patient. So if there is a massive IVC injury, we know that the vena cava is on the right side. So here what we do is something known as an extending cocker with cattle brush, where we take the whole colon, the appendix, ascending colon on one side, but cutting along the white line of Talt, so that the whole peritoneal viscera is diverted to the left side, and then we have the IVC directly visualized. Similarly, if there's an aortic bleeding, then what you can do is that you can do something which is known as a Metox procedure. That means you take the descending colon, the splenic fracture of the colon along with the spleen and the sigmoid by opening the lateral peritoneal fold medially, and then you have aorta at it. So these are some of the procedures which should be done by experts who have done these trauma surgeries. If there's a pelvic fracture and the patient is bleeding, normally it is recommended that you can do a pelvic binder initially or an external fixator, and then you can shift this patient to interventional radiology suite for angiographic embolization. However, all the centers may not be having an interventional radiology. So what you can do is you can do something which is known as pre-peritoneal packing. That means don't open the peritoneum, just go down, push the bladder down along with the peritoneum, and all around that you put mops. Basically, a pressure tamponade is created in the pelvis to stop the bleeding. And after 48 hours, then you can take up once the patient is stabilized. Renal pedicle injury, palpate the other side, otherwise just ligate the vessel and come out. Don't bother about whether this is salvage, because here patient is to be salvaged. But remember this thing, when you're doing this, please palpate the contralateral side. Now, when we want to limit contamination, if you are in a good setup, you can just staple it, bowel clamps, or you can just use umbilical tapes to ligate it, just to control the fecal contamination. Non-circumferential holes, it has been described that if you're good in suturing, you can suture, but if there are a lot of holes, don't try to suture each one. Just take that segment, tie it on both the sides so that there is no leakage from the holes. And most important thing is put big size drains so that you put a good liberal drainage, because good washes and good drainage, so that there is no collection of this contents which are leaking in the peritoneal cavity, resulting in sepsis. You have controlled the initial, you have initially won the war, but later on lose the battle, because if the patient goes in sepsis later on, that is one of the basic things which results in a lot of morbidity and mortality. Control, if you want to have of hemorrhage, it is very important that you know from where it is bleeding and you take a vascular control of those things. Once you have done that, what are you going to do is that you're again going to operate this patient for a definitive surgery. Because if there was a bowel perforation, multiple perforation, you have just tied umbilical tapes and come out. So what you can do is you can either we use a Eurosac bag. People there out abroad, which is the Bogota's bag, but we take a sterile Eurosac bag, open it and suture it to all the edges. This is what we normally do. Others have described even VAC procedure to be done. Don't close the abdomen, just put a VAC dressing. But VAC has resulted in a lot of perforation resulting in sinuses. So that is what we don't want. That there should not be because of negative pressure. There should not be any perforation of the intestines. So normally we are not using that. People have used Proline mesh. There are zippers which are available abroad, but we are not using any of this. What we normally do is we take a Eurosac bag in India and apply it as a Bagota's bag. Now, as I told you that this damage control surgery has been extrapolated to other organ injuries, like in the thorax, they do something which is known as a pulmonary tractotomy. That means they apply staplers all along. If there's a penetrating wound, suppose a bullet injury, the tract through which it has gone, just apply staplers on both the sides of the tract so the bleeding is controlled. Even the cardiac wounds have been stapled, which has been reported in literature, and just pack it and come out. Sometimes even they have twisted the lung on its hilum so that there is no, and later on you can go ahead with lobectomy or pneumonectomy. So vascular injuries, obviously we are talking about unstable patient over here. You take up think whether the limb is viable, not viable. If viable, do a damage control shunt or an early amputation. Now, whenever there is a vascular injury, remember this thing that you should do a fasciotomy, because once you reperfuse this limb, there is going to be edema. And once there is edema, the compartment syndrome compartment syndrome comes into the play, and that results in basic necrosis of the muscles. So please keep in mind that whenever you are doing some revascularization procedure in these trauma patients, do a fasciotomy so that there is no compartment syndrome developing in these patients. Once you have done that and shifted the patient to ICU, the phase 3, this is where the outcome is decided, because your intensive care specialist has to correct the physiology in next 48 to 72 hours. That's the maximum time what he has got, so that you can take up the patient immediately after this. Now, remember this thing is a multidisciplinary team effort, because the surgeon will be also visiting the patient, seeing the color of the train, seeing what is the output. The intensivist will be busy in correction of the hemoglobin, the coagulation parameters, hypothermia, so that he is preparing the patient for the definitive surgery. At the same time, he's keeping alive this patient, because he has undergone not only trauma, but the second surgical insult, what the surgery has been done, a damage control surgery. So normally, these 24 to 48 hours determine the basic morbidity and mortality in such patients. So goal is basically to reverse the sequelae of hypotension, which have occurred because of hypotension and hypoperfusion of the organs. Now here, your intensivist has to be in hand in glove with the surgeon who is treating, because the surgeon can tell him the nature of injury, the amount of injury, what all he is contaminating. Now, once your intensivist has done an excellent job, it now comes back to the surgeon who is going to take up this patient for definitive surgery as phase 4. He will look for hidden injuries when he is doing a definitive repair for intestine. Now, when we talk about missed injuries, they're basically the posterior aspect of the colon, which is not there, like the posterior portion of the hepatic and the splenic flexure of the colon or the transverse mesocolon. So these injuries may be missed, especially in a penetrating injuries. Another thing what the surgeon should know is that when he's trying to control this, when he's trying to, now this time he's going to close the abdomen. When he's going to close the abdomen, in the last 48 to 72 hours, it was an open abdomen. The bowel would have become edematous. And when you push this edematous bowel inside, there are complications of something which is known as abdominal compartment syndrome. What I was talking about compartment syndrome in the limbs, it can also happen in abdomen. So when you're doing this, when you're closing the abdomen, just look at the peak pressure. There should be less than 20 to 30. If they're more than 30, or if there is a increase, initially it was 16 and now it has gone to 30, that means that is not a good peak pressure. The anesthetist will tell you, yes, the abdominal pressure is rising. Another thing is that when you are applying VAC dressings to these open abdomens, there are high chances of anterior cutaneous fistula. And as I told you, sepsis is one of the commonest complications of this, and that is what we have to avoid by early introduction of antibiotics in such cases. Now, how do you recognize that there is an abdominal compartment syndrome? Elevated peak airway pressures, you should be asking your anesthetist when you're closing. If at that time it was fine, but later on the edema is developing, the patient may have oliguria and uria. You can measure abdominal pressure because by putting in a Foley's, you can attach it to a transducer, and then you can even measure it. But all people will not be having this. So it's more of a clinical diagnosis rather than these things. And remember this thing that when you are contemplating, when the abdomen is tense, and you know that there was edematous bowel, which you have tried to just put it inside, that is a time where you will be contemplating that this patient may have abdominal compartment syndrome, which will be seen by oliguria or anuria. And as you progress further, the basic thing is just open up the fascia of the abdomen. That means you can release the abdomen, again apply a Bogota bag if that is happening. So in a patient, if you talk about damage control resuscitation, starts from pre-hospital, goes to hospital, where everything is worked by a team which is going to do that. Now, there have been institutions where there is something known as a riboa. That means if the aorta is bleeding somewhere and you don't have any this thing, what you can do is you can do endovascular balloon occlusion of aorta. This is known as resuscitative endovascular balloon occlusion of aorta. What we do is we go to the femoral artery, go into the aorta, we inflate a balloon at the before the from where it is leaking, so that there is no leak of abdominal aortic injury. However, remember this thing, this can be only done in safe hands who know what they are doing, and it carries a lot of morbidity, especially if the aorta is bleeding above the kidneys. So to summarize, whenever we talk about damage control resuscitation, the first thing is a rapid diagnosis and knowing where to give damage control resuscitation. You should know that you are going to limit crystalloids. You will try to give more of colloids. You will have an element of permissive hypotension in patients who don't have head injury. You can do hemostatic resuscitation by giving it in the ratio platelets to FFPs to RPRBCs in the ratio of 1:1. And immediately do an anatomic control that means anatomic means the surgical control of the contamination and the hemorrhage. And later on shift him to the ICU for maintaining the correction of the physiology. So take home message is damage control resuscitation is a vital part of management of multiple injured patients and should be performed before metabolic exhaustion kills the patient. Delaying the decision to perform DCR contributes to higher morbidity and mortality. At the same time, you should know when and to whom to give this method of treatment. You should be hand in glove with your interventional radiologists, intensivists, anesthetists, OT staff, and that's why a multidisciplinary approach and coordination among various teams gives best results. We always say that preparedness for disaster is the key to successfully managing it. I bring greetings from my Institute, Grand Government Medical College and Surgery Group of Hospitals. I'll be happy to take any questions if there are any questions. I don't know if in the chat box there are any questions. Thank you very much.
Thank you so much, sir, for such an insightful session. Moving on to Ritik. Ritik, please, we have few questions in our Google Forms. So go ahead, on to Ritik.
Thank you, Manu. Thank you, Dr. Girish Bakhshi, sir, for such an insightful discussion. Now, let's move on to the Q&A session. So our first question is, how did you start your journey and how has it benefited you so far?
Journey as a surgeon or journey as a trauma surgeon?
As a trauma surgeon.
Okay, trauma has been a part and parcel of general surgery. Whenever a trauma patient comes, right from a residency at KEM, where the patients used to come in trauma, and they were initially managed, even if it's a limb injury, the initial management was done by general surgeons so that the resuscitation is done. They're stable, because we had an incident where a limb fracture was directly sent to ortho, and unfortunately he collapsed outside waiting for the orthopedician. So that after that incident was made mandatory that general surgeons who are better in managing resuscitative care will be doing that. And this I carried forward when I joined as faculty as assistant professor in the year 2000 in JJ. And we had a lot of trauma victims, not only of the vehicular accident, but in 2001, 2003, 2005, the train blast, and there were blasts near Gateway of India in 2003. And then that was 26/11, where we were at the helm of affairs. We got 166 patients, and we have really improved over a period of time. We had a disaster management plan at that time in 2001, which we improvised in 2003, 2005. And 2005 was a time when we involved psychiatric teams in the beginning. I'll give you a good example. I had a patient, a young child, I think hardly 13 or 14-year-old, and unfortunately, he lost both his parents in a bomb blast. This happened in 2005. Patient had this child never had any injury, but he was in a lot of psychological trauma. As a surgeon, you can handle anything like bleeding, wounds, or this thing, but this is something different. So that's the time when we realized, we talked to our psychiatrists, and that was the time that we incorporated psychiatrists and psychologists as a part of our team, trauma team. And uh, uh, in 2009, we implemented it. And that was something where we were appreciated. By that time, the CDC director had come down in 2000 after this bomb blast on 26/11, Dr. Henry Fogg. So he, in fact, he emphasized, and there was an Israeli team which visited us. And they were very happy to know that we have incorporated psychiatrists. And over a period of time, as you see these trauma victims, you try to evolve as a trauma surgeon. In the beginning, as a surgeon, you are enthusiastic. Okay, I can handle everything single-handedly. It's not possible single-handedly. You have to have a team. And in the beginning, you may say, okay, you can control the bleeding. No, I will just control it rather than packing. It will hardly take 5 minutes. Those 5 minutes, when they turn into half an hour, you don't know. And by the time patient is exhausted. So over a period of time, we all learn. And truly speaking, that over the last 25 years, more than 25 years, we have evolved. Our JJ team, and I think every place has evolved as a better trauma team.
So moving on to the next question. So in neurosurgery, what are the challenges faced in case of trauma?
Neurosurgery, the thing is that these patients there are 2, 3 strategies which you can't do in neurosurgery. That is in DCI, like permissive hypotension, we don't allow in a head injury patient. Second thing is immediate early CT scan is required. However, if the patient is unstable, then we can't move these patients to CT scan. So we have to restrict before we take up these patients to CT scan. Once the patient is taken in CT scan, and if you've got something which is an extradural or subdural with a midline shift, that is the time when the neurosurgeon comes in the picture. The challenges for the neurosurgeon are that when they're taking up for head injury, they should be knowing that there are no other associated injuries, because they may be doing a very good job, excellent job, but if this got a thoracic injury and we have not put a ICD, then once you give him a positive pressure ventilation under general anesthesia, what will happen is he will result in tension pneumothorax. So, there are a lot of challenges where you require both general surgeon and neurosurgeon to work in tandem for the benefit of the patient. So challenges to neurosurgery means becoming a neurosurgeon is easy, but when you manage these patients, becomes challenging how to have the least morbidity, because many times, in spite of doing the best work, you may not have a good, there may be some certain part of the brain which is already gone. That's why.
So the next question is how to manage emergency cardiovascular trauma for general surgeons, because at times like during emergencies it's not really possible to have a cardiothoracic surgeon or a cardiovascular surgeon at hand.
Yeah. Remember one thing, that when we are having a cardiovascular trauma, majority of these injuries, if you just put a drain and come out, will be good enough, like especially the pulmonary trauma. 80% of the pulmonary trauma will heal. When you talk about specific cardiac trauma, that's why I told you ATLS should be done. There is a chance that this patient has a cardiac tamponade. That means the blood because of the cardiac injury is getting collected in the pericardium. So here we can do pericardiocentesis. I always teach FAST, that is focus assessment sonography in trauma, to all general surgeons as well as all trauma surgeons, because it will help us in diagnosing that whether this patient has a cardiac tamponade because of this trauma, and they can put a catheter under USG guidance, under this FAST guidance only, and aspirate the blood. Remember, it is only 50 to 60 ml blood which gets collected in pericardium, but because of the tamponade effect, the patient goes in hypertension because the heart is not getting perfused. So once you have aspirated, it gives you another half an hour to 40 minutes before you shift the patient to OT. So this is one thing which general surgeon should know, because by the time the cardiovascular surgeon comes into the picture, this is the minimum life-saving procedures what he can.
So a participant has asked, if the tamponading effect goes away and it is difficult to find the site of the bleeding, so what should be done in such case?
Tamponading effect means if you have packed the abdomen and the tamponade effect is gone, or tamponade effect, I think because of packing only it should be. Unless until you have
Yeah.
disturbed the packs, the best thing is if you can't find the site of bleeding, put pressure anywhere. That means again pack it, repack it. And if you've got an intervention radiology person, if you are in a setup where intervention radiology, you can do an emergency angiography in your angiography suite and block it. But remember this thing, if you can't feed it, don't try to hunt it. Don't try to catch anything where you can't see exactly the bleeder. It is better to first do good suction. What we do is normally we put pressure first, because with a good towel, what will happen is towel will absorb the surrounding blood. At the same time, it will stop whatsoever is bleeding, or maybe decrease the level of bleeding, the flow of bleeding, and then take a good suction and suck it as you remove the dose. So then you can see it. You should have vascular clamps. That's what I told you, that vascular clamps should be there. And if the tamponadic effect is gone still, then you will have to, if you are in surgery, you can put your pressure with the hand till you call for help and call for vascular clamps to clamp it.
So, there is another question. So can you please explain how to calculate loss of domain in hernia to avoid ACS?
Okay, so loss of domain in hernia is basically calculated by Tanaka's index, which is a CT index, where we calculate the volume of the abdomen, the peritoneal cavity, and the amount of and the volume of the hernial sac. If the volume of hernial sac is more than 25% of the total volume of the peritoneal cavity, that means obviously there is loss of domain.
So one more question, sir. In such cases, it is very important to explain the prognosis to the patient's relatives. So how to go about that?
Yeah, it's very important that you have got a variety of patients and the relatives. The first thing is that be emphatic to them, because try to understand that they're also going through this thing. You will be busy. You must have done a whole night emergency and then this patient has come in the morning. So just talk to them, explain them in very clear language that this patient is critical. We will try every level best to save him. But at the same time, anything can go wrong. He may not respond to our treatment. So that is what we have to be very blunt in that there is chances of death of this patient, because that is something, and keep it documented. That's another thing which we always say, document it on paper, that to explain the poor prognosis to the patient.
Perfect. Uh, Someone has raised a hand. Shubhrat, can you please unmute?
Good evening, sir.
Good evening.
Sir, actually, I am asking that question that when the tamponading effect goes away, coming back to the same question, sometimes it is not possible for in our healthcare system to every time a doctor should be present in the ambulance, right? In that case, the attendees take the patient to the hospital. And sometimes they don't know the reason where that the tamponading effect is due to the knife only. For example, in case of a knife injury.
Yeah. So in case of yeah. Go ahead.
In that case, sometimes the attendees only remove the knife, and we cannot get the exact site of the knife injury, right?
Right.
In that case, what should we do? We should assess it by Q fast or
see, if it's a penetrating injury, you don't require fast. You know that it's penetrated the abdomen, there is going to be this thing, and if patient is unstable, then you obviously go in directly the patient to the theater. If the patient has penetrating injury, yes, direct laparotomy
should be done.
Now the question arises that there is a penetrating injury and the patient is stable. You examine him clinically, you don't find anything. Then you can do a fast. You can also do a CT scan, provided the patient is stable, to know whether the breach is there in the peritoneum. Another thing, what we do is we do a local exploration of the wound. that is it going in the peritoneum or no. If it is going in the peritoneum, exploration is required.
All right.
However,
So in that
yeah.
case,
Hmm.
in that case, if the tamponading effect goes away, that thing will automatically lead to some kind of hemorrhage, one way or other, right?
Right. That means if you have removed the knife, that's what you're telling.
Right. Yeah. Not
Okay.
exactly the doctor, but the attendees.
Okay.
In that case, what would be the fluid of choice, and how should we manage that?
The fluid
We
of
should
choice
do the
in trauma,
transfusion.
you see, the thing is that if you are doing this during shifting of the patient, right? That's what I think
Yeah.
you
Yeah.
are trying to ask.
Yeah.
During shifting of the patient, you don't have patient's blood. So the ideal fluid is a crystalloid, which is isotonic as well as the same osmolarity. So ringer lactate is the ideal fluid for resuscitation. And if you don't have ringer lactate,
Okay.
normal saline. These are the two fluids.
Okay.
At the same time, you can just put external pressure at the site of injury. Nothing more can be done
Mm-hmm.
at that time.
Mm-hmm. All right, sir. Thank you. Uh, and sir, in that case, where you said that laparotomy should be done, then we should do a Euro bag packing, right?
If see why when we are going to do Eurosac, Bogota's bag or
Euro bag.
Euro bag, we are going to do only if the patient is already bled a lot, more than 10 units required, hypothermic patient, coagulopathic patient, and we cannot do a if there is a single injury, that I can understand. If there are multiple injuries, obviously he will go for damage control surgery. Because
All
if
right.
it's going to take more time than 90 minutes of your whatsoever, don't venture into that.
Mm-hmm. Thank you, sir.
Welcome.
So this brings us to an end of our event. We are done with all the questions. So thank you so much everyone for your questions, and thank you so much Dr. Girish Bakhshi sir for your insightful event and your expertise and time. Today's recording of the talk will be available on IEEE's website and YouTube channel for those who missed it or wants to revisit this enlightening discussion. Please take a moment to fill out the post-event feedback form for those who want certificates of attendance. Don't forget to sign up for IEEE's membership. On behalf of the entire IEEE's community, I thank you, sir, for joining us, and we look forward seeing you at our future events as well. Thank you so much, sir, and thank
Thank
you
you.
all the
Thank you very much. Thank you very much.